Okay, good morning, everyone, guys. So, today we are going to discuss everything about congenital heart defects. So, these are the disorders or diseases that are congenital or inborn. So, I believe some of you have already or were already familiar with this during your second years, but we are going to discuss them further here in our subject. So, what are congenital heart defects or CHDs? These are structural defects of the heart, and maybe from the heart, from the great vessels, or both of them, which is present at birth. And it is second to prematurity as a cause of death in the first year of life. Actually, prematurity is not really the cause of death, it's the acute respiratory distress syndrome that premature infants die from due to the lack of lung surfactant. That's why they die from prematurity. Now we go to the four classifications of CHDs. Number one, we have defects with increased pulmonary blood flow. So there's still increased pulmonary flow. So there is blood still flowing through the lungs with these defects. Remember PAVA, PAVA, PAVA. We have patent ductus arteriosus or PDA, atrial septal defect or ASD, ventricular septal defect or VSD, and atrioventricular canal defect or AV canal. So that is PAVA, defects with increased pulmonary blood flow. Now we go to the second one, which is obstructive defect. So there is a blood vessel or portion of the heart that is obstruction, which do not permit blood to flow through it. Remember cap. We have coarctation of the aorta, we have aortic stenosis and pulmonic stenosis. We'll discuss them further here in this subject. The third one, we have defects that decrease pulmonary blood flow. So, meaning there is a decreased blood flow to the lungs in these diseases. We have TT. Remember TT, tricuspid atresia or AT, and we have tetralogy of Fallot or, or TOF. There are four defects under tetralogy of Fallot. Remember PROV, PROV, PROV. What is PROV? That is pulmonic stenosis. We have right ventricular hypertrophy. O stands for overriding of the aorta, and V stands for ventricular septal defect. So remember PROV, that's why it's known as tetralogy. Tetra meaning four. There are four defects associated with this disease. PROV, pulmonic stenosis, right ventricular hypertrophy, overriding of the aorta, and the ventricular septal defect. And number four, we have mixed defects. We have TTH. Remember TTH, transposition of the great vessels, or TGV, or also known as TOGA, transposition of the great arteries. We also have truncus arteriosus and hypoplastic left heart syndrome. Now, what is the exact cause of these disorders? We have it's primarily unknown. We do not know what causes these CHDs to occur, but we have predisposing factors such as fetal and maternal infection, especially during the first trimester of rubella. So anything that the mother has or any viral infection that the mother can have, the fetus is going to be susceptible in these infections, most especially during the first trimester, because the first trimester of pregnancy is the phase where the fetus is still undergoing organogenesis. When we say organogenesis, that is where the fetus is still developing their organs, the vital organs such as the brain and the heart and all the other internal organs of the body. And if the mother is also an alcoholic, that's also a predisposing factor. Age of 40 and above. That's why females do not wait for your age to be more than 40 years in order for you to bear a child. You should have, or the best age, according to a UK study, for a female to bear a child is from 20 to 35 years old. 20 to 35 is the optimum age of child bearing. Another is maternal dietary deficiencies. So it's very, very important for us to teach mothers on how nutrition is important during pregnancy, most especially proteins, certain vitamins like folic acid, and so on. But folic acid is not related to this, to CHDs. It's more related to, what do you call this? To neural tube defects. So that's dietary deficiency. Next, we have maternal insulin dependent induced diabetes. So it's one of the predisposing factors of CHDs, or a sibling who has a CHD. That's also a predisposing factor, or also a parent with CHD. It can be genetic, or chromosomal abnormalities such as having trisomy 21 or Down syndrome. Usually, patients who have Down syndrome also has a coexisting or comorbidity of CHD. Others, teratogenic drugs such as thalidomide. Thalidomide do not only cause the infant to have amelia or phocomelia, it can also cause the or fetus to develop CHDs. Or certain antivirals or antibiotics such as sulfonamides and tetracyclines should not be given to pregnant women since they can cause or they can precipitate CHDs, or even anti-epileptics such as phenytoin. So these are patients who have chromosomal abnormalities. So they are susceptible in developing CHDs. We have trisomy 21, even Klinefelter syndrome. They have coexisting CHDs. Now we go to the differences between the two. We have acyanotic and cyanotic CHDs. Acyanotic, we have left to right shunting. So left to right shunting, this means that due to the opening in between the either the atria or the ventricles, the blood flow will be coming from the left to the right. So it's not yet dangerous because some of the oxygenated blood from the left side of the heart will be mixing with the unoxygenated blood at the right side of the heart. That's why the skin color of infants who have acyanotic CHD is still normal. They still have a normal CNS function. Position is normal and orthopnic, but they may have a small stature or may develop failure to thrive. So, what is failure to thrive? It's a condition in infants wherein they are unable to grow or maintain growth. Remember, there are two instances in the life of a person where growth is rapidly occurring. That is during infancy and during puberty. Now, due to the CHDs, either acyanotic or cyanotic, they can have failure to thrive. That's why they have a small stature. They cannot maintain the growth due to the CHD. So it's expected that the growth of these infants are somehow slow or regressed. And there's possible exercise intolerance in acyanotic heart disease. And there will be increased frequency of respiratory infection with infants who even have a cyanotic heart disease. Next, cyanotic. There's now right to left shunting. So this is dangerous because the blood from the right side of the heart, which is unoxygenated, will immediately shunt to the left, bypassing now the pulmonary artery, which is supplying the lungs with unoxygenated blood in order for the blood to gather oxygen. Now, since it is bypassed, the patient who has a cyanotic heart disease is appearing cyanotic. They are blue in color because the blood of infants with cyanotic heart disease did not collect oxygen from the lungs. It bypassed it due to this right to left shunting. And it cannot this occurs with CNS alterations due to the lack of oxygen circulating in the body due to hypoxia, such as seizures, fainting, and confusion. And the best position, I forgot to tell you, in acyanotic, they can be placed in a normal position or a thopnic position if they are having difficulty of breathing. But for patients who have cyanotic heart disease, the best position to place them in would be a squatting position in order to increase blood flow to the head. I'll explain that later if we are going to discuss the tetralogy of flow. They will also have a small stature due to failure to thrive. And if the patient who has acyanotic heart disease have possible exercise intolerance, this time they cannot do any exercise the um, due to lack of energy because of hypoxia. Of course, if you lack oxygen in your blood, how are you going to perform that exercise? And there will be frequent and severe respiratory infection and hypoxic spells, most especially for the trilogy of Follow. So you should all well know these structures by now. So this is an infant who's suffering from a tet spell. We'll discuss that further once we are already under tetralogy of Flow. So is how they look like if they appear cyanotic. Look at the lips. So acyanotic, this is mixing of oxygenated and unoxygenated blood into the pulmonary circulation, resulting to decreased oxygenated blood in the systemic circulation. So some of that oxygenated blood at the left side of the heart goes back into the right side. So what are these acyanotic heart diseases? Remember PAPACAV. PAPACAV. Patent ductus arteriosus, atrial septal defect, pulmonic stenosis, aortic stenosis, coarctation of the aorta, atrioventricular canal defect, and ventricular septal defect. So we have that mnemonic, PAPACAV. Now talk about ventricular septal defect first. It's the most common CHD that we have under the acyanotic CHDs, and it's characterized by an abnormal opening between the right and left ventricles. And the degree of this defect may vary from a pinhole to an absent septum. So as you can see here from this illustration, this area between the ventricles, there is an abnormal opening in between them. This is the normal one, but the abnormal has an abnormal opening. It varies in size from one patient to another. So types of VSD, where the low septum VSD, the defect is small and may spontaneously close as the infant grows older, and no further treatment is needed for this. But for high septum VSD, it has a large defect. It do not close spontaneously, and it will require surgical intervention in order to close the defect. So, such as this one, we have the high septum defect and the low septum defect here. Letter A is the high septum defect, letter B is the low septum defect. Clinical manifestations, it will vary depending on the size of the defect, the age, and the amount of resistance. Usually, it is asymptomatic. And there may be a loud, harsh systolic murmur that you can hear at the left sternal border, and it is heard at the third to fourth intercostal space. That may also, or the patient may also exhibit dyspnea and tachypnea. Failure to thrive may occur, and excessive sweating and fatigue. Usually, fatigue may be felt by the infant after they feed or after drinking milk. Remember, infants spend their energy through sucking, through breastfeeding or bottle feeding. That is where the infant's energy is consumed, and they are going to feel very tired immediately after feeding due to the decreased level of oxygen circulating in their body. And they are also going to suffer from respiratory infections. Now, if this defect complicates and it is left untreated, signs and symptoms of congestive heart failure may be present later in life. So we do not want that to occur. This needs to be treated immediately once detected in order to prevent the occurrence of heart failure later on. Diagnostics, chest x-ray or ECG may be done, but the confirmatory test for all types of congenital heart defects would be 2D echo or echocardiography. So that's um, the diagnostic procedure. They are just going to use a sonogram in order to detect the defect. Medical and surgical management, some VSDs may close spontaneously, while others may be closed by using a Dacron patch, requiring cardiopulmonary bypass. And it's recommended for children who have very large defects or who has pulmonary artery hypertension, heart failure, recurrent infection, or those with failure to thrive. Now, pulmonary artery banding is a palliative procedure. When we say palliative, it's to treat the pulmonary artery hypertension. It's not curative. It's just relieving the signs and symptoms of VSD. And this is a procedure done for those who are poor surgical candidates. So this is the Dacron patch that they are going to apply over that defect to close the patent um, patent septum between the ventricles. So this is an example of having a septal defect, ventricular septal defect. And this is a Dacron patch. So it's just like applying a patch on a cloth, on a linen with a hole. And this is the pulmonary artery banding. It's a palliative treatment in order to relieve the patient from pulmonary hypertension due to the increased blood flow at the right side of the heart due to the left to right shunting. Next, we have atrial septal defect, an abnormal communication between the two atria, which results when the atrial septal tissue does not fuse properly during embryonic development. And the severity again depends on the size and location. So this time, instead of the ventricles having an opening in between them, it's the atria that's having an abnormal opening in between them. That's ASD. So infants who have this usually are asymptomatic until early childhood. I have a classmate before in nursing who had this. And she was, yes, she was a she. She was asymptomatic until college. She was operated on when she was already in college. And This classmate of mine is a close friend, and she's one of those classmates who can be very boisterous in class, very noisy, very talkative, but very friendly as well. But we didn't know that she had this. So when there was a time when we did a medical checkup or a physical examination, I think the doctor who examined her detected a heart murmur, and they required to do further tests on her, and she was diagnosed to have this by doing 2D echo. Many defects of ASD may close spontaneously by the age of 5, but it depends on the size of the defect. Fatigue and dyspnea on exertion are the most common signs and symptoms of this disease, and there's slow weight gain and frequent respiration infection. But take note that classmate of mine was a very tall female. She's around 5'8" in height, but she was very thin. So probably due to her CHD. There is a systolic ejection murmur that may be felt or may be auscultated, and it's usually prominent at the second intercostal space at the pulmonic area, since this defect is found in the atrial level. And the S2 sound is split, so you may auscultate this sound, lub dub dub, lub dub dub, lub dub dub. Again, the surgical procedure that is done here is through applying a Dacron patch or suturing if it's just small. And it will require cardiopulmonary bypass because this is an open heart surgery. CP bypass is going to be done. Cardiopulmonary bypass is where uh, the body's oxygenated by a machine instead of the lungs due to this operation, and it is usually performed during school age. But in her case, it was done during her college years. Or closure can be done by cardiac catheterization. It may be done by using a special coil or umbrella, most especially for a defect that is just small. So this is the coil that may be used to close it. Now we go to PDA. This results when the fetal ductus arteriosus fails to close completely after birth. The ductus arteriosus is a normal fetal blood vessel. It's a special type of blood vessel present during the fetal age, together with the ductus venosus and the foramen ovale. But they should close after birth. But if it fails to close after birth, this will result patent ductus arteriosus. This ductus arteriosus should become ligamentum arteriosum that will secure the aortic arch onto the pulmonary artery. But since it remains open, there will be an abnormal connection later on between the aorta and the pulmonary artery. And it's the most common anomaly with mothers who were infected by rubella during the first trimester of pregnancy. So as you can see here, that PDA connects the aortic arch to the pulmonary artery. Now, this again left to right shunting. The heart is not involved here, but the great vessels of the heart are the ones involved. So instead of it being transformed into a ligament, it didn't close after birth. If the defect is small, the child may be asymptomatic, and a loud machine-like murmur may be accompanied by a thrill. There might be frequent respiratory infections that may be associated with this. Poor feeding may result, and due to fatigue, the infant is too tired to feed. Remember, their energy spent during feeding. There might be hepatosplenomegaly, poor weight gain, tachypnea, tachycardia, and irritability seen in the child. There's one pulse pressure, and a bounding pulse may be felt from the child. So this one, it usually closes as well around 8 to 12 weeks after birth. But if it doesn't close, maybe surgical attention may be needed. And watch out for signs and symptoms of heart failure if this is left untreated, since heart failure again is a complication. Medical and surgical management. The doctors are going to do medical management first. They are going to administer prostaglandin synthetase inhibitors, such as indomethacin in premature infants. This will cause the closure of the patent ductus arteriosus, this drug. But if closure is unsuccessful, surgical ligation is going to be done next via left thoracotomy. So they're going to make an opening in the left thorax without CP bypass. And it is, of course, video assisted, this type of surgery. They're just going to ligate that patent ductus arteriosus. So they are going to um, incise or do ligation on that patent arteriosus and close it via sutures. Or a coil closure can be done as well via cardiac catheterization. So that's how they do it. They are going to use a catheter in order, together with, of course, angiography to visualize the catheter, and insert a coil in between them or in that patent ductus arteriosus in order for it to be closed. Now we go to the coarctation of the aorta, which involves the local narrowing of the aorta. And there are three types. We have the preductal, postductal, and juxtaductal coarctation of the aorta. What are these? The preductal coarctation occurs after, or here in this illustration, the preductal occurs before the aortic arch, while the, or no, no, no. Preductal occurs before the ductus arteriosus. I mean, before the ductus arteriosus. Juxtaductal is occurring at the ductus arteriosus, while the postductal coarctation occurs after the ductus arteriosus. And remember, in coarctation of the aorta, the ductus arteriosus remains open. It remains open. So as you can see here in this illustration, letter A is the juxtaductal, letter C is postductal, and letter B is preductal coarctation of the aorta. As you can see in these illustrations here, there is narrowing of the aorta. Again, the child may be asymptomatic or may experience classic difference in blood pressure. This is a sign. This is a classic sign of coarctation of the aorta. If there is a difference between the blood pressure of the upper extremities and the lower extremities, if you are going to assess the blood pressure of the upper extremity, usually for the upper extremity, they have increased blood pressure. While for the lower extremity, there is decreased blood pressure. Why? Look at this. Remember these branches of the aortic arch. These arteries branching out of the aortic arch are supplying the head and the upper extremities with oxygenated. Now, due to this narrowing that you can see here in this illustration, blood will it is difficult for the blood to go down the aorta due to this narrowing. So where will it go? It will go up. It will go to the head. It will go to the upper extremities. That's why the pressure in the upper extremities are greater than the blood pressure of the lower extremities because of the decreased blood flow in the aorta after the aortic arch due to this narrowing. So you are going to feel increased BP on the upper extremities and decreased BP in the lower ones. Even the pulse, you are going to feel a bounding pulse in the upper extremities while a weak pulse at the lower extremities. Now, other signs and symptoms present would be epistaxis or nose bleeding due to the increased pressure in the head, headaches, fainting, lower leg muscle cramps due to decreased oxygenation of the lower extremities. Systolic murmur may be heard over the left anterior chest between the scapulae posteriorly, and rib notching may be observed in an older child. So as you can see here, these coarctations depends on the severity as well. So there you go. Diagnostics, again, the same diagnostic procedures are going to be done to the echo is very, very important in the diagnosis of this defect. Medical surgical management, again, they are going to repair this through surgery. They're going to do anastomosis. How is anastomosis done? They're going to remove the stenotic area, the narrowed area, and stitch together the areas of the aorta that does not have anastomosis. That is, or that does not have the stenotic area. This is known as anastomosis. Bypass surgery is not needed because repair takes place outside of the heart. Or non-surgical repair is done first via balloon angioplasty. Again, in balloon angioplasty, cardiac catheterization is done here. A balloon tip catheter will be inserted and inflate that balloon at the area of the stenosis. But if this is unsuccessful, surgical management is going to be done now. Now we go to pulmonic stenosis. This is obstruction of blood flow from the right ventricle to the into the pulmonary artery due to the narrowing of the pulmonic valve. So as you can see here, the pulmonic valve is narrowed. So there's decreased blood flow into the pulmonary artery, therefore decreasing the blood flow into the lungs. So there. Clinical manifestations. Child may be asymptomatic or may have a mild congestive heart failure. Stolic murmur may be heard over the pulmonic area, and a thrill may be palpated if the narrowing is severe or stenosis is severe. In severe cases, there's decreased exercise tolerance, dyspnea, precordial pain, so they're going to feel chest pain, and generalized cyanosis may occur. Diagnostics, of course, again, ECG together with chest x-ray will be done. Cardiac catheterization will determine the degree of narrowing, and to the echo again will be done, not mentioned here. Balloon angioplasty is going to be done in order to open that narrowing. But if balloon angioplasty is unsuccessful, again, balloon angioplasty is done through cardiac catheterization. Surgical valvulotomy or valvulotomy may be performed. Valvulotomy is creating an opening in that valve. Next, aortic stenosis. It's similar to pulmonic stenosis, but this time the aortic valve is the one that is narrow. So leading now to decreased output, cardiac output. And remember, CHDs, not only this one, it's more common in males than females. But for aortic stenosis, it's also more common in males. Clinical manifestations. A child with a very severe defect or severe narrowing may have a faint pulse. There's, of course, hypotension due to the lack of oxygen being delivered into the aorta, tachycardia, and a poor feeding pattern because children who have aortic stenosis may be very tired. They do not have the energy to feed. So a child may experience signs of exercise intolerance, again, chest pain, dizziness if they are standing for long periods. A systolic ejection murmur may be heard at the second intercostal space. So this is a normal aortic valve. It has a wide opening, but for children who have aortic stenosis, they may only have two valve leaflets leading to that stenotic aortic valve. So balloon angioplasty again may be done first to dilate that narrowed valve. But if it is unsuccessful and there are signs and symptoms or the signs and symptoms are severe, Again, valvulotomy or prosthetic valve replacement is necessary to be done on the child. Next, atrioventricular canal defect. There's incomplete fusion of the endocardial cushion, and it's more common in patients who have trisomy 21. And again, the shunting here is left to right, although blood may flow among all heart chambers. Signs and symptoms are similar to ASD. So as you can see here, there is an abnormal opening in all chambers of the heart. So all chambers are affected here. And it is coexisting for patients who have Down syndrome or trisomy 21. Take note, Down syndrome is the same with trisomy 21. So there you go. Um, Treatment here are the following. Similar to the one previously discussed, PAB or pulmonary artery banding is going to be done, but this is just palliative, it's temporary. And the child will need surgery in order to close the valves, to close that abnormal opening in all four structures. So this one, this ASD, this is atrioventricular canal defect. This is aortic stenosis. This one is VSD, of course. This one is patent ductus arteriosus. So we'll discuss this next week about all the cyanotic heart diseases. So if you have any questions about the acyanotic heart diseases that I have discussed for today, please do not hesitate to send me a message. So review it or read in advance the topic for cyanotic heart diseases. Again, thank you very much for attending today's class. Have a great day, everyone. Bye.